Nancy has a much better interpretation of what we were charged to do. She says she sparks your thoughts, and I thought I was supposed to light you all on fire, which is definitely not right. Oh my God. Okay, so yeah, at the end of my presentation, duck. Just kidding. I'm Laura Gottlieb. I'm in the UCSF Department of Family and Community Medicine. So it is no secret to this audience that over the last few years, there's been a dramatic increase in the buzz focused on the role of the healthcare sector in addressing patient social determinants of health. The experiments we've seen have included everything from activities focused on community organizing and political advocacy to encounter-based, patient-focused efforts to identify and address social needs in the context of clinical care delivery. That buzz has in large part come about because of at least two things. First, over the last 2 decades, there's been a surge in the amount of research connecting social and economic risk factors and health outcomes, largely provided by Dr. Williams and many of his colleagues. And second, those connections resonate with all of you, with healthcare providers, especially in healthcare settings serving low-income patients and populations. That research scratches an itch. So putting aside for a minute the critical public health, policy work, community work at play to address these determinants and to improve health equity that Lloyd is going to talk about after my presentation, I'm going to suggest that healthcare teams themselves can do better to use information about patients' social and economic risks to shape the delivery of care at the encounter level. Some of this is stuff we do every day in the safety net, though not always well or methodically. We provide what I call social determinants of health informed care. For instance, we dose medications around work schedules. We open evening and weekend clinics. We send out mobile vans. We invite interpreters into our clinics. But if we're aiming for health equity, perhaps we could actually make some small changes in patients' social and economic circumstances, even within the context of the clinical encounter. For instance, we can help patients connect with food resources rather than changing insulin doses at the end of the month when food benefits run out. We can help patients connect with vocational service programs instead of giving them free transportation vouchers to our clinics. We might link them with English as a second language programs in addition to providing interpreter services. Not surprisingly, many of the innovators in this space are concentrated in primary care. In some cases, they're the very people in this room. They include medical providers and medical professional organizations like the National Academy of Medicine, the Robert Graham Center, many primary care associations across the country, and some of the organizations that Dr. Williams mentioned in his talk, like the National Center for Medical Legal Partnership and Health Leads. This list here is by no means exhaustive. But despite the surge in enthusiasm from these organizations, the evidence on what actually works to improve health for patients by addressing their social and economic needs has lagged far behind the innovation curve. Just to drive home that point, this slide shows the results of a literature review that we conducted this year at UCSF. The dark blue bars show literature published in PubMed since 2000, just containing the words social determinants of health. The green bars show literature published that contain the terms social determinants of health and healthcare. So we're seeing 400 or more articles published every year now related to social determinants of health and healthcare. But then our team tried to find evaluations of social needs interventions conducted in healthcare settings, and now you see these tiny red dots added to the graph. You're not supposed to see them. You don't have to crank your heads. Between 2000 and 2016, only 67 studies were published on interventions to address patient social determinants of health in the context of care delivery. And of those, fewer than 10% were rated as high-quality studies. So last year, we launched the Social Interventions Research and Evaluation Network, or SIREN, which catalyzes and disseminates research on social determinants of health interventions undertaken in clinical settings. Siren currently has an open call for proposals that I encourage all of you to check out. Our CFP complements other work we're doing at UCSF as the RWJ-supported program Evidence for Action, which also has an open call for research proposals on the health and health equity impacts of both healthcare and non-healthcare interventions. Even when we eventually have better evidence in this field, we're going to need to work to ensure that those evidence-based programs become part of the standard of care. Bob Phillips will talk more about this afternoon, but today I want to just plant this one last seed. Despite recent position papers on poverty and health from the American Academy of Pediatrics and the AAFP, if we really want to include social and economic needs as a core part of high-quality primary care and as one part of a more comprehensive strategy to achieve health equity in this country, we'll need to ask our professional organizations to do more to support this work, like actively lobby for payment reform to reflect the clinical work and the clinical workforce necessary to provide these programs. That includes supporting electronic health record tools and other resources that are going to help programs implement these kinds of interventions. So the last thing I'm going to do before Mal kicks me off the stage is to recruit you to join our small group session following the Ignite presentations, where we're going to explore these 4 key questions. What's the real responsibility of primary care in identifying and addressing patients' social and economic needs as a piece of a strategy for advancing health equity? What work's happening in this field, and how do we better coordinate those efforts? How can we increase both evidence and evidence-based practice? How could our professional organizations catalyze more work at the intersection of medical and social care? So I'm looking forward to the next 2 days of conversations about these questions and others, and we'll turn it over to Lloyd.